Thank you very much to be here, and it was really a pleasure to give you help on the beginning of your reform and to be a little bit useful. It's little help, yeah. When you say I'm a psychiatrist, I'm not sure. I'm trained like psychiatrist, but I'm not sure I have this classical identity as a psychiatrist. I prefer to be human being than a psychiatrist. A psychiatrist are sometimes part of the solutions, but very often part of the problem. And going back to a story, we have to go 30 years back to 1990, when our country became free, and we as a young doctors and psychologists took the freedom. We've been very unhappy with working in the hospital. We left the hospitals and started to build up some kind of alternatives, which was not easy, but it was a freedom. We've been young, full of energy. And when I left my ward, I didn't took with me a nurses because they were too institutionalized. I took the cleaning ladies. They were really those cleaning ladies. They were really like cleaning, but chatting with the clients, having real relationship. And that's how we started community services. We had first conference, much bigger than this one, 1993, about reform. And then we tried to communicate with health system, but it was such rigid that we left the umbrella of health and we start to develop these services under the social field, which I think it was good choice, because looking what's going on in many countries, that you can spend a lot of energy by fighting with this old-fashioned institutional medical model. And it's much better to sometimes, at least it was in our case, to start on the green grass, to build up together with the users new culture, and then be strong enough to come as a partner to the medical field, as an equal partner to start a build new system. That's what's going on just now. As it was mentioned by Lydia, also by Roberto, I think the main is changing a culture. That's not really about a building. But it's clear that in institutions you will have always institutional culture. You can't change, you can make hospitals nicer, but never more inclusive. It will be always there. Just don't believe that you will change your hospital to be a good place for living. Never. It'll never happen. But of course, even in community services, you can have institutional culture if you don't change your thinking. That's, as I said on the beginning, what we decided to start community services, mostly with those that have been never working in mental health fields, because just those working in mental health fields means working in the hospitals were very institutionalized. And that's quite about a power, how you share a power, how you empower, yeah, and how those who are powerless give a power. I think it seems like very easy, but that's what we see. It's a story which goes just now in Russia, Ukraine. You know, it's a story about ourselves, and it's just human story. That you have really to think about deinstitutionalization and not trans-institutionalization, because what very often happens, then you move your people from the institution to social care homes. And this data which we have, for example, WHO data, they are only partly true, because there is probably the same number, even higher number of those sentenced to life penalty to be in social care homes. That you have always think about, it's not just moving from one institution to another. Even the support housing could be very much institution. Even the house for person with sex can become very much institution, sometimes even worse, because there is less control. That what we, for example, prefer just now, it's really housing first. It means to give everyone, even those being 20 years in the hospital, give them the flat and flexibly support them in their own flat. This is their own kingdom, it's not our space, because shelter house is always our space, it's not their space. And it's about empowerment, really. Not to create daycare centers. It's a bubble, just to go and to support people, to use a normal clubs, to go and to be employed and open employment. There are technologies which allow you, and when we change this shelter workshop to the principle of individual placement and support, we really could employ even those they've been 20 years in the hospital. Yeah, in fact, I'm not so happy with the term of community mental health center. I prefer community mental health team. And ideally, we saw it in the COVID time, that our team were really virtual because they couldn't come together. They were online, they meet every morning online, and they didn't need a building. Yeah, because they go and they visit the clients, and it was perfect. That I think, don't think so much about buildings, think about people and relationships. That's more important. Of course, you will need some acute beds, but if your crisis interventions are well done, the number of beds could be very low, as Roberto said already. Yeah? Just don't start too much building acute beds in general hospitals, but start to build alternative in the community, and after that maybe to build acute beds. Yeah? Because then you will see you will need much less than you supposed on the beginning. I think this what we started thinking 30 years ago, and I think it's evolution. Every maybe decade it goes a little bit more widespread in more details, but always it's about how to implement human rights. I think it's a quite different philosophy as 30 years ago than the doctors said what should be done, how services should looks like, and also we use term psychiatry. Just now I think it's the other way around. Human rights says what we as a doctors should do. Yeah? That we shouldn't be a masters. The masters should be human rights framework. I think this is just to change from treatment to recovery. It doesn't mean to use the tools of medical or other, but with the framework of recovery. And the clients should be really the masters of the plans, and not we as a doctors. We should be as experts. And also in community mental health team, the doctors are not leaders, they are like experts, and they are professional managers who lead the teams. I think that's another. We as a doctors, we have to step back from our ambitions to be managers. Maybe some of us could be good managers, but mostly not. Just being some kind of resource and for the teams, and who is really intensively linking with the clients are case managers. And in our teams we have a parity of social workers and nurses. I think it's important that it brings, as I said, we develop these community services, community teams, mostly with the social workers. Just now we move nurses in, and this I will recommend as a good model, because just it really balance this risk of reductionistic medical or psychotherapy, whatever model. That I think all these topic is permanently 30 years active. I think the changing financing is just now a little bit going better, because just the health insurance is more trying to find the motivation for the big hospitals to close down the beds, yeah, because before they've been paid for the number of beds, just now the acute services are paid by the diagnosis, DRG, but don't use the abbreviation. And as longer they keep clients in the hospital, as less they receive money. That means, and if we build one community mental health team, the 20 beds should be closed down. It means the cost of 20 beds is move from the institutional budget to community budget. And we do have a plan, then until 2030, it will be half and half. Just now it's about 70% still goes from the health, go to the beds, it means acute beds in general hospital and the larger hospitals, and only 30% goes to the community services. And we hope in another 7 years it will be at least half and half, and the number of beds will reduce also on half. That we use the European funds for infrastructure in general hospitals to have more modern facilities. We had 30 acute departments in general hospitals. No money went to the big hospitals. It was just a rule. And all money from this project went to working with regions, because they've been very important, and each region's been supported to have the institutionalization plan. It means the plan, what kind of services we need for all type of mental health needs. We need to build up together with the regions in the community, not to use the hospitals. That every regions, I will recommend you to do so, every regions, and our regions are just from 500,000 to 1 million, has proved plan what has to be built up in the next 7 years, that these beds will be not used. In parallel, all hospital has also to work on transformation plan. It means if in a community there will be such service, we will close such number of beds. It's not ideal, some of them are resistant, but at least they start to think this way, and they should update the transformation plan every year and present to the Ministry of Health, because Ministry of Health is the master of all our big hospitals. Then it was important to work on the sustainable financing, that we had agreement with the health insurance that new community services are covered, and it's already go on. And also together with the Ministry of Social Welfare, it's agreed that this part of social staff is in the general plans of each county. And then the counties are asking for the money, Ministry of Social Welfare, and it's the midterm plan. And if you once put these services to county midterm plan, you are sure you will get the money. That we manage in these, let's say, 4 years of the project money to make those services we develop be sustainable, and also open the doors for the development of new services, but with the condition that we really have to be active in the reduction of number of beds in the big institution. In the same time, we've been very much busy with helping everyone in the field to really communicate community services with the inpatient services, regional management with the project teams, and etc. And it was very much on personal level that our community mental health team are coming to the acute hospitals or general or psychiatric hospitals nearly every day. The case managers are following their clients even they are admitted to the hospital. They sit down with the staff and they prepare discharge plan nearly the day where the person is admitted. By that, we cut the number of admissions dramatically. Also, length of stay is much reduced. That I think this intensive cooperation between community teams and hospitals are very important. But what I still see that we moved out of the hospitals, and these community services are not fully dependent on hospitals. I see it as advantage, which is a little bit different as your model. And I think your model have a lot of maybe advantages, but also disadvantages, a risk that it will be really like dependent of institutions. And to change it is really not easy. I think it's very important to have the coordination of national level that we have on the level of government. There is the committee of the reform, where there is a Minister of Health, Ministry of Social Welfare, and other relevant ministries as a justice, education. They meet every 2 months. There is an action plan, and they follow how the action plan is implemented. There is the coordination committee on every county level. As I said, they make the plans and the implementation of the plans. There is the office on the level of Ministry of Health, and there is advisory body where the clients and users are involved. And that's, I think it was not so much mentioned in the previous speeches, but a little bit was. But I think another big issue is nothing about us without us. It means, I don't know how many users we have here. Yeah, I don't know. I don't want you to ask you to raise your hands. But I think at least 1/3 of those being in this room should be users. I think that's really a changing how we use our power. That we do have representative users in every committee and the regional level and governmental level. We do have in our teams are peer workers. In every team should be at least 1 or 2. It means those who has experience with mental health and being treated in mental health facilities, and they are employed as a staff with specific role to be very much near to the clients with the same experience, and also to give the feedback to the teams about what is the feeling of the clients, because just not having experience, and most of us don't know, we could be really like delusional in our thinking what is helping. I think, as I mentioned already, the transformation plan of each hospitals are very important, and if you don't have it, just start to work on them. Don't care what will happen with the building. The buildings will find their way. I think they could be definitely not for health and social services. It will make the calculation how much it will cost to structured our hospital for some kind of social health care, not mental. It will be a huge amount. It is much cheaper to build a new facility that renovate this. This could be university, maybe it could be public housing or whatever. Yeah, but I think you have to give up your ambitions to keep your hospitals. It's separation process, especially for psychiatrists. Yeah, you say we've been there 100 years. That's the tradition. Well, that's very good tradition. It's very good time to say bye and make it as a museum, but not to be obsessed to keep it. I remember with one institution, there was a long discussion if we will leave the institution, how will it be horrible for the clients. Luckily what happened, roof fall down, and we have to leave the institution 24 hours. And all these fantasies was happened been gone, you know. The community very easily accept those living in these institutions. An institution, a castle, was sell and just now is a luxury hotel, you know. But we discuss years how it will be used, and it should be used for the services. The God help us. You know? But God is not helping every time. Sometimes we have to help ourselves. Just please, like, forgot your idea to keep your hospitals. Think about people, not about a building. And a part of what can help you is the transformation plan. And it has to go together with the plan of the region. Social, health, education, that you should be clear what has to happen in the community, but don't wait that first you will build all complex community services and then you can move clients from the hospital. It has to go in parallel. Of course, the bridging funds is needed and useful. It means some money which is like for certain time as above a usual budget, but also that's important to plan, because as longer this transformation time is, it's more costly. That the planning, coordination, communication, not to think in the medical line, but really comprehensive, that's a key point of your success in the future. You can have a fantasy to build up a 300 community mental health teams, but it has to be really based on reality. Yeah, just you will never build 300 without really dramatic reduction of the capacity of mental health hospitals, because you are not such rich as Dutch. They manage, but just now they have the highest number of beds in the Europe. I don't think it's a good example how to do so. Luckily, we are not such rich, and we have to be more economic in our thinking. That's what I said, that we decided a little bit differently than you to use this community social services, mental health services, resources, merge together with the hospital staff and created the new teams. I think I better say teams, as I said, and as again, I think maybe they even don't need a building because they are working where the people lives, and create the teams where they really work on recovery philosophy, nurses, social workers, psychologists, psychiatrists. Together we have about 15-20 people who about 100,000 inhabitants, but we focused on those with really severe needs, yeah? Because that's always, you have to be clear in your priority. The people with mild needs, they have a primary mental health care, they have the psychologists, psychiatrists, daycare center, that's all exists. But our community mental health team are really focused more on those who are in the risk of rehabilitation, hospitalization, revolving door syndrome. And the teams care for 2-3 years, maybe longer, yeah. And then it's not this intensive care is not necessary. They do the discharge plan for as much normal community support as possible. That it means this is like really comprehensive thinking, as it was mentioned. That's not only about the team as such; it's about team as a facilitator and supporter of community. And I think our workers are doing maybe 1/3 of the work is not with the clients, but with the community, to make the community open and not to just be like babysitter for the clients. And of course, as it was meant, to use the resources in the community, that in most of our teams we have a specialist who is specialist on mobilizing the workplaces in open market and supporting clients to get there. They can fail, but that doesn't matter because they all go on and go on. Better than to have these workshops or whatever. As I said, the same is with the housing. Yeah? Just I think we leave the idea of this shelter housing as Trieste did, and we go more to get the social flats or just the social benefits for the clients. And it's also important that the clients can ask for different social benefits as support for housing, money supporting housing, and they can go more or less to open market of housing, being individually supported by the teams. That it means the mobilizing and using the community is definitely important. And as more you are fixed in the building as a community mental health center, as less you have a feeling for community. I think, could you imagine that your team didn't have any buildings? They will be linked with the mobiles and on calls, and their offices will be cafe. That's what I'm more or less doing, you know, that my office is cafe. Yeah, it's not a... Yeah. Of course, you need a little bit subsidy because this cafe is just no expensive. But these subsidies are less than renting a building. Yeah. And then the number of beds goes down, that we are building just now a little bit acute beds also in the mental health hospitals, but it will go down, and we believe that for our country it will be enough to have about 4,000 beds in general. It means like this is quite a reduction, and there is a perspective, let's say, next 7 years, that the number of beds will cut on half, and the community services will be developed up to 100 teams or one teams in every 100,000 inhabitants for general mental health, and also community mental health team for other type of needs, as a children, geriatric, and forensic, which is already going as a pilot. That it means the European funds been really useful to support those things which are developing already 30 years, spread it, being mainstream, being accepted on a national level, and I think it's a big change. But as I said, preparation was quite long. Maybe you will be much more quicker than we been. I think that help us to have tools to cut the barriers for those being still in institution and include them to the community, which is not finished, but I think we are on the way. But we have to cooperate, all of us, and also we need to cooperate internationally. And I hope this will be start a cooperation between Poland and Czech, because to go to Hradec Králové, it's much quicker than go to Warsaw. Yeah, that you have 2 hours, and they have excellent services. You have excellent services. That I think the next weekend we can meet in Hradec Králové. Thank you very much.
Dziękuję bardzo.
Dziękuję bardzo.